Hello, everyone. I hope that people are joining us today. Always, it's great to see everyone. Anyway, so today is our fourth Q&A. I hope people have liked that. Let me know if how the audio is sounding. Last week, I noticed that my big blue microphone was kind of fading in and out when I was going back and forth. And I think I updated some drivers and I made a few changes, and I'm actually trying a different microphone. And so we'll see if that works better. Just let me know. Um, Sign in the chats if you're here. Say hi. Um, so today I'm going to talk a little bit about geriatrics. I'm going to start off with that. Obviously, for the Q&A, we're open to everything. Cannabis, of course, geriatrics, hospice, palliative care. Feel free to throw anything that you pressing questions you might have. Meanwhile, I am also going to just say I have a lecture today at 5 o'clock Central Time um, for a group called SoMe Docs, Doctors on Social Media. They have regular conferences, and they have one on new and integrative ways to control pain. I'll be doing mine, of course, on cannabis and pain. So, yeah. So today, what I wanted to talk a little bit about was in geriatrics and Alzheimer's. 7 million people in America have Alzheimer's. I've talked before how about not all dementia is Alzheimer's. And so sometimes people have other things like vascular dementia or frontotemporal dementia or Lewy body dementia. And this also applies to them when I talk about this, when I talk about dementia and the loss of function that people have with dementia. So, what happens with dementia? Well, we often think of it as memory loss. We're like, oh my gosh, they remember things from 50 years ago. They can't have dementia. I hear that all the time. But of course, they can't remember what they did yesterday. For that matter, they can't remember how to get dressed because people with dementia lose their abilities in the opposite direction that children develop it. And so, what's very interesting about this is, in a sad sort of way, is but it helps you to think about dementia a little bit. It's more than just memory, it's functional losses that people lose. So, that ability to live by themselves gets progressively lost. Um, so, if you think of a child, like any child, as they develop, they become progressively more and more independent. They develop skills. They can walk, they can toilet themselves, they can feed themselves. Eventually, that moves up to they can actually put their own clothes on, to they can actually pick out their own clothes and put it on. And they can brush their teeth and they can take a shower by themselves. They don't need to be bathed anymore. They can now, you're now getting into middle school. They can do a lot more by themselves. They can walk to school by themselves. You get to high school, they can drive. Oh gosh, I have teenagers. you know, they can drive. As you get, you can handle a job, you can handle a paycheck, you can handle money. And so what happens is people, become more and more able. As people get dementia, one of the very first things to go is one of the very last things that a child develops, money and driving. So suddenly grandma's getting parking, violations. Well, not with parking, but driving, pulled over by a cop. Or you're like, oh, I'm not sure you should be driving. She runs a stoplight, she does a few things, and you're like, I don't know about that grandma. And, every now and then you hear really catastrophically sad stories where someone confuses the brake and the accelerator and plows into something, accidentally. And so you hear these stories. And then, so driving, that ability to handle a car. The second thing that goes is money. So people who are older are a little bit more likely to be scammed, is one of the first things that can happen. The second thing you might see is the person who used to write all the checks suddenly isn't. Maybe they had everything on auto pay, but they're not keeping up with it. So the bills suddenly start going unpaid. And you're like, what's happening here? You were an accountant. You handled this your whole life. Why is it now not working? Well, because they lost the higher math functions to be able to handle money. And so then as dementia develops, then you start seeing things that maybe like an 8th grader, now they can't drive, right? Now you wouldn't necessarily trust them with money. Now you're like, can they cook? You know, and that's where you run into issues. My husband, his parents had issues, and his when his mother got really bad dementia, she lost the ability to cook, and him or her and her husband weren't eating very well because her husband didn't even know how to cook, and so and he also had a little dementia, God rest his soul. Anyway, so the ability to feed yourself, or the ability to cook for yourself, right? Then you go down, and now maybe a middle schooler. Now maybe someone needs to lay your clothes out for you. You can still get dressed. But if someone didn't do that, you might just stay in your pajamas all day or not even get dressed, or you might just wear the same dirty clothes. Now someone needs to do your laundry for you. Now someone needs to go to the grocery store, and cook something for you. Um, then you go even further. Now you're at a toddler level, right? Now you're having falling. And that's a huge issue because for a toddler, they're made of cartilage and they're 3 feet from the ground. When they fall 2 feet, they bounce. A 6 foot man with brittle bones is not going to bounce when they fall. So falls become a big issue because they actually lose the ability to walk. Um, they lose all these different abilities as they continue to go on. In fact, one of the very first things that a baby does, eat, right? The baby's born, you give it to mom, and you know, and the baby gets fed, right? That is the first thing that happens, and that's one of the last things that happens at the end of life in Alzheimer's. Alzheimer's is a terminal condition. People die from Alzheimer's. Um, and they are, it's a terminal condition. And one of the ways people die is they stop eating and drinking food that they enjoyed. It starts a little bit back at what I would call that toddler stage, right? Where they they're not eating well. One of the things that can happen is food textures. It becomes hard to chew, it hard to swallow. People actually go from, they can't eat steak anymore. They can't eat uh, things that require a lot of chewing. Then they even have trouble, even moderate chewing, crackers, whatnot, right? Finally, literally, people are fed baby food, parade diet, right, to eat. And so you lose the ability to physically eat just like a child does. And then the other thing is you become kind of picky like a toddler does. It's like, I don't want to eat that. I want to eat this. I want to eat this. The taste buds become a little bit more number. They don't have as good sense of taste. And so people, as they get older, really sort of lose that ability. Now, then what happens is that at the very end, they stop eating altogether. And that's actually a natural part of dementia. There's still doctors out there who will be like, oh, we should put a feeding tube in them. But study after study has shown that feeding tubes actually hurt at the end of life with Alzheimer's dementia. what you end up doing is you end up giving them, um, you end up giving people nutrition, kinda, but it's not really the good stuff that helps them, and the rest of the body continues to deteriorate, and you increase their risk of infection, you increase their risk of bed sores when you actually give them a tube feed. Plus, people don't like it, they pull it out, they have to go back and forth to the hospital every time it gets pulled out. It can get infected, it can get fungus in it. It's not a nice thing. I mean, there are times that a tube feed is very appropriate for certain medical conditions. It's just that end-stage dementia is not one of them. Um, Really, the standard of care is to hand feed people lovingly, affectionately, right? Whatever they can tolerate until they can't. And then, talk hospice and let them eat and enjoy what they can and let them call the shots. That's kind of how we do that. So that loss of function is very notable in dementia. Now, one of the things that we see with that, though, is that as that function declines, right, people lose the ability to care for themselves. You know, just like a high schooler would, might be able to care for themselves for a day or two, with some, my high school still lives at home, obviously, right? Even college kids, you kind of check in on periodically. How you doing? How's it going? Let me drop you off some food, right? There's that point where people really have difficulty living by themselves. Now, we do have programs that can help some people. And so what we look at actually is what's called the ADLs and the IADLs. So ADLs, activities of daily living, are the extreme, most basic things that you have to be doing to be able to live independently-ish. I say ish because you probably are going to need some support if this is all you can do. But a person who has their ADLs can go to the bathroom by themselves. They can put food to their mouth and feed themselves. They can clean themselves, not necessarily shower and bathe, but they can do basic hygiene, right? Brush their teeth, wash their face, kind of keep themselves clean, right? They can they can transfer. Transferring is not walking. That's an important thing to know. If you're wheelchair bound, but you know how to transfer from your wheelchair to a bed and from the wheelchair to a toilet, all you need is a ramp and you're going to be fine. There are many people who are wheelchair bound who live independently. Transfer. So we say transfer instead of walking. So toileting, feeding, transferring, bathing, hygiene, right? Putting clothes on, right? So can you put your own clothes on? So these are some of the things that people need to be able to do if they're going to be alone for most of the time. Now, we have programs like Meals for Wheels, Meals on Wheels, for people who can't cook for themselves and can't grocery shop. We have transportation programs for people who can't drive anymore. We have these sort of support programs available that can help people with what we call IADLs, independent activities of daily living. This is what you need to do if you want to live completely by yourself with no one bothering you. You need to be able to get to the grocery store. You need to be able to communicate, call 911. So they got the little buttons right now that you can hit if instead of having to call on a phone. You can call on things like there's Meals on. I said Meals on Wheels. T. So you have all these different social programs that can help with your IADLs. And so what happens is we have some supports, but there's going to be a point with dementia where people need help. They can't live by themselves. And because they can't live by themselves, we need arrangements to help them. And so there are different ways and different things that are available. The ideal thing would be to age in place, right? To not have to move from your home, to live where you're at. But then some people have homes that have multiple stairs and that's not safe anymore. Or some people have no one to be with them. So sometimes you have a family member. Probably the most common thing that happens is you're going to have a family member who says, okay, I'm going to go move in with mom, or mom's going to move in with me, and I'm going to take care of them. A lot of times that falls on the women, though I have seen a handful of men who are the sons who take good care of their parents. But that's it very extra strain. Now you have caregiving. You're dealing with the emotional, the person who was the child mentally is now the parent, right? They're taking care of someone whose mental status is going down. And so that type of thing, that stress is a huge thing. And a lot of times, it's the family member who's closest, right, or nearby, or maybe the one who has, oh, they don't have kids that they have to take care of, or so they suddenly find it imposed on themselves, and they're like, okay, I'm going to be a good child and take care of my mom, and that can cause a lot of emotional burdens. So that's why in geriatrics, we actually talk about it being a family treatment. It's not just the patient, because a lot of times, the person doing the caring is really stressed themselves. And in fact, there's some studies to show that in certain circumstances, the person being cared for outlives the caregiver, because that cortisol, that stress, increases your risk of heart attacks. It increases your risk of chronic disease. And so all these things cause problems. And so we want to be very conscientious about that. And so that's where, again, you get the social work involved. How can we help you? What programs can we enact? Now, if the person has enough money, because unfortunately, in most states, there's not a subsidy for this. You can hire a caregiver to come in. Now, there is, again, in that person who can mostly live by themselves but need some help, you can actually, there's a program called a homemaker. And the state, for people who have a certain income threshold, can have a homemaker come in 4 hours a week. Sometimes it can be as much as 4 hours a day, 5 days a week. Usually there's no help over the weekend, but that homemaker can be very helpful if a caregiver maybe wants to do some work or something like that. They can sort of tag team. Or if the person's independent but maybe needs someone to cook their dinners or to kind of cook their meals, but otherwise they're safe to be home alone at night, that homemaker can do a little bit of light housework and maybe get some meal prep. So there's that available. But again, when you have a caregiver, when you have a family member who's a caregiver, which is the most common thing, is extremely stressful. Now, if they have the money, you can actually pay for a live-in person. That's beyond the hours that the state provides for homemakers. There's a lot of agencies that will do that. Kind of like nannies, right? Just like we've had for children, you have a nanny, you can hire someone like that. It's usually out of pocket. Usually, if you have the money to buy that, you're probably not qualifying to be poor enough to have the homemaker program. Sometimes there's a little window there, but generally speaking, it's going to be expensive. But the person gets to stay in their home if you have a good person doing the caring. That's a great thing. Now, then there's nursing homes and assisted living. Now, assisted living is usually a cash only thing. There are some assisted livings that are designed for people on public aid. There's a handful of them. And they are, the person lives in a little apartment light. There's usually CNAs who come. They do some of like the remind them to take their meds. A nurse might come by, say, don't forget to take your pills. And the meals will be provided for them. And there'll be someone who does housekeeping. There'll be a CNA who will check them with some light duty things, help them get dressed, whatnot. Um, and there's sometimes different levels. Some of these assisted living programs will in fact have dementia care programs where they have a little bit more intensive care for people with dementia. But there often is sort of a cutoff below which a person is too dependent for assisted living. And then there's skilled care nursing home. Now, if you just came from a hospital and you've had a 3-day stay, qualifying stay, which means you actually had to be there for something sick, you were sick, Medicare will pay for a nursing home for 20 days at 100% and 80 days at 80% if you still have a need, which means if you're fine and you're doing well, they stop paying. If you no longer can do rehab, even if you're not fine, if you're plateau, you're not getting better, you're like, "Nope, this is your new normal." Um, Medicare just cuts it off. So Medicare will pay for a small amount of time, but then for the long custodial care, that again is usually out of pocket. Now, if someone's poor enough, you can do what's called a spend down, where they spend their money, and then through the Medicaid program, they can get nursing home care. Um, but usually you're spending all your assets and stuff like that. And nursing home care, it can be good, it can be bad. I've seen a lot of bad. I've worked throughout the city in Chicago, and but that's how nursing homes are, you know. So not the best thing, but sometimes they're what we have. So those are kind of your different options. And it's important to know this because as someone starts to get dementia, this is a conversation you're going to have. You know, this is, and it can be hard because people with dementia sometimes don't realize they have dementia and they don't want to talk about it. And sometimes, you have to involve the whole family and, who's the power of attorney, who's not, are all the kids making decisions together? You know, these types of things are important, and it's important to have that conversation earlier than later, because later it becomes hard when it becomes an emergency. You know, the I don't see any questions up. I don't know if anyone's here yet with questions. It's not popping up on my screen here. Um, nope, still nothing here. I do hope we get some people coming in. Until then, we'll give a holler and talk. One of the things that when we talk about institutional care, there are two things pertinent. One, let's talk a little bit. It's now officially June. We talk LGBT care and all this stuff. We should be talking about it every time, or every month of the year, of course. But since it is June and we're talking about institutional care, that is one very interesting point. Is that a lot of institutions, depending on where they're at or who they're with or whatnot, can be very difficult for an LGBT uh, elder and senior to deal with. It can be very hard because you may have someone, I have seen 70-year-old transgender patients, they came out in the 90s and have been transgender and identified. Is that nursing home going to respect that? You want to make sure, or that assisted living, or are they going to give them a room and assign them, to the gender they were born with instead of the gender they identify with, right? Um, are they going to be able to live with their partner, if they both go? Sometimes A couple, might go move in together to an assisted living. Is that going to be a problem? Generally, these days, that's not, but it's always something very important to talk about. Is someone as they get older, actually, as speaking of LGBT care, it's important to make sure that everything is planned in advance because sometimes what happens is if you're not married to someone in specific, if you're married, because of the marriage laws, that trumps things. The spouse is the top decision maker for you. But then what happens is as someone if you're not, then you might have children. You might have siblings or other people who come in. And if you're debilitated at the end of life, they may try to make decisions that you wouldn't want. Years and years ago, I had a patient. She actually wrote on her advance directives, I do not want to go to Texas with my sister. And she put that in black and white on her advance directives. I laughed. It's like, "Oh, that's funny. Oh, that's great." Until the sister showed up. The sister showed up and wanted to bring her back to Texas. I'm like, "I have an advanced directive form." Of course, the sister's like, "Oh, that's all. I have a new one." And well, the patient had a stroke. Her memory wasn't very good, and so her decision making wasn't intact. And the sister went to the facility and said, "I'm the sister. I'm the next of kin. I'm going to take her to Texas. I'm taking her to Texas now." And I had a big old meeting. I said, "You can't do that. You can't override this power of attorney because she's not decisional anymore." And the sister grabbed the wheelchair. I was like, "I'm taking her." I in one of these moments that I got in the door jam and I got in her way and I said, "You are not the power of attorney. That paper is not valid. You cannot make decisions for her. If you leave with her, I will call the cops and have you arrested for kidnapping." Thankfully, I didn't actually have to follow up on that because she just turned back around, and eventually a judge determined that the sister was not the person and that her partner was her rightful decision maker. But the moral of the story is again, with dementia, as the memory starts to go and stuff, especially if you're in the LGBT community, you need to have a conversation earlier than later about who is important to you and who gets to make decisions for you. Now, the are we da, 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 Jeanette. Okay, Jeanette is saying that people are not seeing that I'm not seeing the Q&A answers. Okay, so what I'm going to do, thanks for texting me on that. I really appreciate that. Okay, so I don't know why Restream isn't showing it. So let me go to it on my phone and see if the answers are showing up here. Okay. And I'll turn the volume down. Oh, oh my gosh. I am seeing so many. Okay, here we go. So, Jeanette, so I wanted to ask a general question you've been wondering about. Try typing, oh, you know what? Are you doing it in the live thing? On the event? Yeah, it looks like it. Because I'm showing up live on there. Okay, I'm going to leave this open on my phone so I can catch questions. I don't know why. So, anyway, thanks for letting me know about that. I don't know what's going on there. Um, and let me go to your question because you actually messaged it. So, okay. Yeah. So, oh, that's an interesting question. So, Well, I think we kind of finished up the questions about the LGBT elderly. If anyone has any other thoughts on that. Um, and that's weird that the chat is not acting up. Um, but the what was I going to say about that? Oh, sorry, just got a little bit flummoxed that the chat was acting up so weird. So let me get to Jeanette's question. Hi, Dr. Janice. I wanted to ask a general question that I've been wondering about. For people that are on muscle relaxers, could a concentrate such as RSO cause dangerous levels of hypertension? I wrote the question, but I couldn't see. That is a good question. I mean, because muscle relaxers are different, you know, muscle relaxers are, have a lot of side effects. They can make you very tired. I've not known cannabis to cause a hypotension with it, but it's a good question to just hear. I mean, yeah, muscle relax can cause tiredness. Yeah, that would do. I would be a little bit concerned about combining them at the same time. Would you be talking about taking them together? Here we go. Combinationdrugs.com. Okay, so using cyclobenzaprine may increase dizziness, drowsiness, confusion, difficulty, impaired thinking and judging. So I'm looking this up in one of the drugs databases here. And I'm not heard of it causing a lot of hypotension. Obviously, I would be very careful. I would use super low doses and not amp up. I certainly would say talk to your doctor, about this a little bit. But I'm not seeing where it's causing hypotension. I'll look up a little bit more and I'll put a follow-up on it this week because I think that's a good question just to kind of talk a little bit about the drugs that can interact. But it doesn't seem to, when I look it up on the databases, I'm not seeing a hypotension with that. Anyone else with questions today here? I'm all too happy just to keep talking. The I wonder if anyone else message me if you have questions. It seems that it's not showing up on my live feed, but I'm going to just go here real quick and see if I go back to my live feed. Yeah. Oh, William testing. Yeah, William, I'm not getting it either. Um, Yeah, thanks, William. So what I'm doing is I actually have my phone right here and I can read the stream on it. It's a little weird because it's like echoing, but I have the volume down. So yeah, go ahead and put your questions up there. And then meanwhile, might hypotension be caused by RSO and a blood pressure medication? That's a good question. Well, I mean, yeah, that might be because I mean, the thing is that I've not known cannabis to cause a lot of hypotension, you know. Are you experiencing some hypotension when you take it? Is that what's been going on? Um, and BP meds. I mean, the other thing to know is RSO is really strong. You're supposed to just be taking a grain of rice, and that's part of the reason I don't like it. I think the dosages of it are really. um, are really strong. And so hyperten so let me go back to that and see much appreciated. Okay. So yeah, we'll look up on it a little bit more and I'll get back to you. Now, I guess we're still, if people have questions, chime in. Thanks again for the um, letting me know about the issues with this. So that is weird. Why is it not? It's supposed to feed into that. Hmm. Okay. Anyway, so now let's go back to, I'll just go and talk a little bit more about the nursing home stuff while we're at it. I'll keep an eye out over here on the phone to see if anyone else has questions. So the other thing, so we talked a little bit about LGBT in nursing home and some of the challenges there that because people might be in places that do or don't respect, how they are and their life and everything like that, that it can be a challenge. Now, the other thing we run into is cannabis. Another thing, because it's Schedule 1. A lot of these places, they are federally illegal, and so they can't let you use it. Um, Interestingly enough, I think my some of my nursing homes in some of the rougher, poorer parts of the neighborhoods, some of your nursing homes that maybe weren't the best homes, also were a little bit more open to, mm, as long as you do it outside, people would be using it. But generally speaking, you have someone who's been using cannabis their whole life, and now they can't get it. I mean, sometimes in hospice, in the hospitals and stuff like that, I just kind of look the other way if they had gummies, right? They're using, and we know it, But generally speaking, ugh, thanks, Jeanette. Thanks, William. Yeah. So William texts that he's definitely seen experience where cannabis can affect the blood pressure. Actually, William, I'm going to ask you, what doses have you seen that at? And the because I guess the thing I've often heard about it is sometimes it can cause hypertension, but yeah, I'm s hmm. Anyway, so cannabis in nursing homes. Oh, so one of the things we run into in the geriatric population is, you could have someone potentially go through withdrawal. They're going to a nursing home, they've been smoking every day forever, and now they can't, you know, and that becomes a real big challenge for people who are older. And so that's one thing. The other about that is let's say you are living with someone. You know, one of the things that I've ran into hospice is that people, when they smoke, if they're smoking, it's in the air. And it's an occupational hazard for me. I'm visiting them. I was like, oh, I'm really glad this is my last visit of the day because there's so much smoke. And I'm like, my clothes smell like it. And the next, if I had another patient, they're going to question, doctor, what are you doing? And so it's an occupational hazard when you have home visits. And so I would often caution people, please be very conscientious of where your home, who's coming to your house and when you smoke, when you start needing people to come to your house, you know, or better yet, hey, better yet, switch to gummies, switch to an elixir, switch to an RSO, switch to something other than smoking. 'Cause especially as you get near the end of life and stuff like that, you might need oxygen, and that's not gonna mix well with smoking. So and of course, if you do have to go into a facility or something like that, they're not gonna want you to smoke. So that's one other thing that I run into is, me as a caregiver when people are smoking. Or I've actually had cases, it's quite the opposite, where it's the caregiver who smokes. And I had one case where the home nurse could not come into the house because, again, the caregiver was the one smoking so much, and it just wasn't safe from their standpoint. The what else about that? Yeah. So, I don't see any more questions here today. We'll hang out here. Mm, Now, what else? Talking a little bit about advanced directives, I touched on this a little bit when I talked about my patient who was had a partner, and the partner, didn't have PO. Well, they had POA, but it was in a pre. This is years ago before marriage was legal, and so the partner didn't have the say if someone tried to overrule the POA, which, like I said, thankfully didn't happen. But regardless of your situation, it's important to really talk about advanced directives. You know, I talk about feeding tubes early on. When people are first diagnosed, one of the earliest conversations I have is feeding tubes. Because a lot of times the reason people wind up with feeding tubes is because the person stopped eating. They're just starting to decline. Maybe they are in a facility and their family is in another state. And the facility says, oh, they're not eating. They're a little dehydrated. We had to send them to the hospital. Now the hospital has an on call doctor who's like, oh, no, I guess we should put a feeding tube in them. And then the family member gets a call at 3 in the morning from another state saying, we need you to sign a consent for us to do this procedure on your mom because otherwise she'll starve to death. And it's like, oh, as a palliative doctor, because it's not what's happening. It's the end of the situation. And a lot of times with a little bit of hydration, treatment of whatever infection is, they will start eating again. And eventually they will decline. Now, what you want to do is continue to, support them. But that feeding tube, the data of that, right, is that it doesn't help, as we mentioned. But if we talk early, when you still kind of have some wishes and desires, when you still can care for yourself, if we have these conversations early with dementia and say, this doesn't happen to everyone, but we know that with dementia, people continue to decline and people may need help living by themselves. People may need help taking care of themselves, and they may lose the ability to eat as part of the dementia. What we need to do then is talk to people and say, let's continue to talk about what to do next. Let's talk about advanced directives. Let's get some stuff on paper. Let's get some stuff written down saying, okay, if you get to the point where you don't want to eat, should we put a feeding tube in you? Yes or no? And this is the benefits, this is the risks. And you can say yes. It's not what I would want for someone I love, but you do have the right to say yes. You can also talk about things like CPR. And CPR is an interesting thing. We'll touch on this, and I'll probably say this many times in my career yet. CPR is not what you think it is. We see it on television, right? Where people are doing chest compressions over and over and over. They do chest compressions and they put the little breathing and then they bring out the things they clear and they go shock. That's the CPR. We do CPR in very specific situations. One of them is where the heart's going dangerously fast. We call that VTAC, ventricle, the big part of the heart that does most of the work. It's beating so fast. It's going boop 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 like this, so fast that it's not effectively working. And because of that, you're not pumping blood. And we the other thing that we see is VFib. You'll hear, some doctors show they're in VFib and then they get the paddles again, right? VFib is where it's moving like a bag of worms. Each cell is acting individually instead of being a nice contraction. And that's a really dangerous. Both of those are dangerous. But VFib, there's no pumping. Your heart has stopped. But the cells are moving. The cells are still alive. They're just not working together. Shocking. When we shock someone in CPR, right? That is actually stopping the heart. It's actually a hard reboot, like when your computer does the little blue screen of death, right? This is literally your body's version of that, right? And then what we do is the electricity electrocutes the heart, stops the heart, and then we pray to God it restarts normal. It's just like when you do a hard reboot on your computer and you hit the start key and you hold it for 10 seconds and then you pray to God it restarts normal. That is what the shocking in CPR is. Now, there's a second time in CPR we do CPR, and that is someone who has someone whose heart has completely stopped. When their heart has completely stopped, there's no electricity. We see this on TV with the flatline. It's amazing the number of times people come back from flatlines on TV because it's so dramatic looking. Because the line goes, dee, and of course, the music swells, and then you get a little blip, blip, and they come back. And next scene, they're chasing the bad guy again, right? But that's no electricity. That's turning on your computer, and all you get is a blank screen. And maybe you get that little blinky light in the corner that blinks a certain code. And if you look it up, you'll find that it tells you there's something wrong with your motherboard. But otherwise, you try, if you don't see even that, you try plugging in the computer, right? You try seeing what's going on with the computer, see if maybe I didn't do something, but mostly try to plug it in and see if it's just out of juice, and you hope to God that's the case. But when it's really just broken and there's no sign of life in your computer, it's dead, 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 right? Turning it on and off doesn't help. It's the same thing because it's already off. So when you have a flat line, there's no reason to shock because there's no electricity. You can't turn it off because it's already off. So flatline is really sort of dead. There are a handful of reasons why we do CPR on a flatline, because you're going to see, like, if someone's drowning and it's hypothermic, then actually in hypothermia, you might get a flatline. And so you're going to do CPR to try to warm up the body and see if the heart will continue to pump. There are certain toxins, high potassium, and you're doing a bunch of emergency things at that time to try to get it back down, to try to get out of that flat line. And so there are certain conditions that can create that, where the electricity of the heart isn't working. And then what you do is, so you're doing CPR, but a lot of times when you see that flat line, it's a sign that it's the end. So that's kind of what CPR is, right? You're doing the chest compressions, and the chest compressions, If you've ever watched Dr. Mike, he's chest compressions, chest compressions, chest compressions. That buys you time. That gets you moving. That keeps circulation going while we're trying to bring you back, trying to get the heart pumping on its own. But it's buying you time for us to get the electricity going right, for the heart to be pumping right. Now, CPR, you know, for me, it makes sense. For you, it might make sense. You know, if I get zapped by something, lightning or electrocuted or hit by a car or something, yeah, I'm going to want you to do CPR on me, right? If I have a heart attack, yes, and I hope I don't. Um, but at the end of life, when someone is at the end of life and dying, say whatever disease they have is at its very end, CPR becomes unnecessary suffering because we're doing all this. So we talk a little bit about CPR and what to do and if it should be done when we talk about advanced directives. So a lot of times that can change. So early in a disease course, like even with dementia, someone might say, no, no, go ahead, try and bring me back. And then later on, it may not make as much sense when someone's at the very end and they're dying. CPR is not going to change the overall condition of their disease state. Now, the other thing that happens though, and the reason we talk about that is because sometimes you get people back. And then sometimes when you get them back, they've been down and they've had brain damage, or they've been down and they have multiple organ damage, or whatever caused it is still continuing, right? And now you get kind of this gray area, and it's like, or sometimes when I was in the COVID era, you get people who are still with us, and maybe they don't get CPR yet, but they're on a ventilator, maxed out, and their kidneys are failing and their liver is failing. And it's like, you're not going to stop this, at this point. But there becomes this question. Sometimes there's a gray area even before that, where the liver and the kidneys are okay and they stabilize, but a person's on a ventilator because they can't breathe on their own. Maybe they had a heart attack, but now they can't breathe on their own. Or maybe they had COVID and now they can't breathe on their own and you have a breathing tube. This is another thing you want to talk about is whether you want the breathing tube. How long? When you do CPR, invariably you get the breathing tube put in, but hopefully if you get better, they take it out. But the question is, do you have lung issues so that the breathing tube is coming out, is needed? Are you so dependent on it that you need the breathing tube? Now, if you go beyond 2 weeks or so, in COVID, it was so. They would actually keep people on longer because of the nature of COVID, especially during the first and second waves of it. The next thing they do is they actually put a hole in your neck and put the breathing tube through the hole. This is good for certain circumstances because it can decrease infection. It can even allow certain people to talk and do other interactions. Christopher Reeve was a classic example of where this would be strongly indicated. He had an injury to his neck, his spine, that affected his ability to breathe. And so the tube went into his neck, and that allowed him to interact and everything. The other thing is that you have to be heavily sedated when you have it in your mouth because that gag reflex is just unbearable. So the hole in the neck makes it tolerable for someone who's awake and about and living their life. But if you say, I don't want to be the rest of my life on a machine, you can put that in advanced directives. So now I kind of jumped around a little bit, but advanced directives, in Illinois, we actually have what's called a POST form. And you actually say 3 different things. First, if my heart stops, I'm dead. Good Lord has taken me, well, more or less, right? My heart has stopped. Do you want CPR or not? And then you say, regardless of that statement, I'm in the hospital. Now I'm very sick. Do I want aggressive care? Do I want, I can list like, do I want dialysis or something like that? But specifically, do I want a feeding? Do I want a breathing tube? And do I want just a trial for a week or two? Or do I want it never? Or do I want it permanently? Doesn't matter. Keep me alive no matter what. Um, and then the third option is feeding tube, right? So again, short term, like I'm in the ICU and you have a breathing tube down me and we're trying to keep me alive, maybe a feeding tube for short term, and those they usually put in the nose and then down into the stomach. But you don't want a long-term one. And there's a term in the ICU where we call that a peg in a trach, where someone is not getting better and they're probably going to live their life in a nursing home on a breathing tube or a long-term care LTAC. It's a type of facility that can handle ventilators. And they put a trach, and then a peg is a term for the feeding tube. And so that they can feed you and that you can breathe through the trach. My husband knows that if they're talking a peg and a trach and they're asking him and not me, that's the line I don't want to cross. That's my personal take. But everyone has their own view on these things. So I do encourage people to talk earlier about where they live, where they want to live, about advanced directives, what they want done. So early in the conversation with dementia as opposed to later is a great thing. So, yes. And I will try to figure out what's going on, why before next week, why we could not get any questions up on my screen. That's really annoying. Thank you guys. And Jeanette, I'm going to look up a little bit more on this because while I agree that cannabis can affect the blood pressure, I'm not sure about its interaction with these medications. And I want to get back with you on that. Anyway, thank you so much for watching. I hope you guys all have a great day. Take care. It's 3:57. Does anyone else have any questions? Otherwise, I might wrap up a couple minutes early. I do have another lecture I have to prep for. So, and make sure the tech is working for that one. The mm, Does anyone else have anything they'd like to say? But otherwise, have a great